So it's with great pleasure now. Many years ago, when I was a baby academic, I got told that part of being an academic is you have to supervise master's students. And I thought, oh, that wasn't in the job description. And then I had the pleasure of being introduced to Laura, who at the time was doing her master's in public health. That seemed, I don't know how long it is, but I know she's had children and things since, so it's probably quite a while ago. But for those of you that haven't had the pleasure of meeting Laura yet, she is passionate. I think that's the word I would assign to her the most. And she has had so many roles within our health setting over the 2 decades that I've known her. She's worked in healthcare, including midwifery. She's been a clinical researcher. She's done a lot of stuff in service development and service leadership roles. And she's worked in various health authorities, because we keep changing what we're doing, throughout Aotearoa, and taken on significant leadership positions in there. And it's been a real pleasure for me to stalk her over her career and see what she's up to. So ho mai te paki kia Laura.
Thanks, Zeus. Tēnā koutou katoa. Ngā mihi nui ki ngā mana whenua, ngā mihi nui rangatira Suze. Ko waio, ko maukatiri te maunga, ko rakihuri te awa, ko Ngāti Hamo ko tipuna, ko waitaha hau, talofa lava, ma LauraAileone o loo ingo LauraAileone. I was just thinking then, I think it could be like 15 years, Suze. I don't know. It feels like a long time, but that's one of the reasons I said yes to Nina above you, even though I've been saying to everyone I was cursing Nina probably yesterday as I did my last of my PowerPoint tailoring and changes and thinking, what can I say to you all that will be interesting and helpful and useful in this time, in this environment. So hopefully a little bit of what I go through today will be helpful for all of you working in our health system, which is going through significant substantive change. Sorry, I stopped for a moment. I thought I had another slide before this, but I guess the key reason I do what I do, and probably the key reason why many of us in this room do what we do, really is for change, because we don't want our children and our grandchildren and actually the generations that come after us to inherit the same system we inherited for health and actually for Hawaii as a whole. We want to see a different system and we want to see change. And I stand here today, I've realised I didn't say my role. So my current role is Chief Midwife for Te Whatu Ora, Health New Zealand. But what I'm going to go through today is sort of a little bit of a, I was thinking of it like a train journey, a little bit of a tour quickly, because I'll be checking and looking at Suze when she tells me 5 minutes, a bit of a whistle-stop tour through some other roles that I've had in the system, because I've been in this new role, national role. This is week 4, the end of week 4, so I'm still pretty new in this role. And so I want to go through 3 pieces of change that have been quite substantive in my life, but actually quite substantive in terms of models of care, workforce change, service development change, and then also from a national perspective. So I'm going to give a bit of a overview of what we did on the West Coast, and that was really a medical workforce change that became a wider multidisciplinary model of care change here in this building, actually just down the way, Waitaha, a maternity service and workforce change. And then my role previous to this was in Te Aka Whai Ora, so was in Te Aka Whai Ora as the General Manager of Hospital and Specialist Services. So what we were doing before the disestablishment of Te Aka Whai Ora in regards to service monitoring change for hospital and specialist services. So hopefully I thought I'll cover all my bases, a few different things, and hopefully you get something out of this change talk today. I put up that quote because I thought it was a really good one. We are all in the midst of change, whether that be personally, professionally, particularly in the system that we're in at the moment. Every day, I don't know about you all, but every day we seem to get another curveball or another thing coming out of left field. We were like, okay, we're going this way, we're going that way, we're going that way. And so I think actually, even if you take nothing else from my talk, hopefully you do take in this, which is change is probably the only constant in our lives, and the way that we adapt and respond to change makes a hell of a difference to how we experience things within our lives. So I'll start with my whistle stop tour. So the first stop that we're going to make is West Coast. So West Coast, I worked for actually almost 8 years between here and the West Coast, and with lots of different roles. But one of the roles that I worked on was the working with my medical and midwifery and nursing and allied health colleagues on implementing what we call a rural generalist model. So another, just really quickly, the west coast of the South Island, around about 33,000 in terms of population, but massively geographically vast, as you all know. It's one of the most sort of isolated and sparsely populated rural districts in our country. The model we have on the West Coast, and we've had for years, not now, but we've had for years, is basically an urban hospital model that we've applied on a rural hospital. And that's no different to lots of our rural settings and rural hospitals around the Motu. That's just what we've done. We've gone urban, put it on rural, and that will work. Well, it doesn't, as we all know. And the research shows us this. In terms of what was before we started implementing rural generalism, is we had probably the West Coast, actually, now that I'm thinking about it, when you look at all the graphs of all the hospitals around the country, West Coast is an anomaly because it was anomaly in terms of how much it was costing to run that model, because you have to basically staff 24/7 for an acute roster, and to be able to do that you need SMOs, nurses, midwives in every single area, every single specialty, even though you might not have the volume of daytime work. So there's that mismatch of acute versus elective work. We've always been integrated with Waitaha as the tertiary provider, but we just never had a model that was more specific to rural. So what was the key issue for us? This is a photo of the old building. For those of you who do know the coast, that was our ED before it was demolished, and now we've got our new Taniko, which looks far better than that. So the key issue for us is, how do we address the unmet need in primary care? And again, a little bit of an anomaly. So West Coast is different in that it owns the primary care continuum. It owns the majority of the primary care practices, so which is different from other parts of the country. There was general agreement that the traditional specialist-based model was not sustainable, and we were looking at what could we put in place that was clinically and culturally appropriate, evidence-based, tamir, that would also allow better recruitment and retention. Because the other thing, which might not be as evident to you all, was West Coast has the probably not the enviable position of having in the past had the highest locum usage of any hospital in our country. Huge locum usage. And when I first started working there, I think we were like at 65% locum usage. Those locums would come from South Africa, Australia, there was another, but predominantly South Africa and Australia. And so you can imagine, when you're getting people who aren't even from this country coming in for a locum, there's quite a lot in terms of not understanding cultural safety, cultural responsiveness, cultural competency. We had at one stage one of the highest HDC complaint rates. So anyway, you can just see it's a recipe for disaster. So what was our solution? I've got to go fast, I know, otherwise I'll stay forever on West Coast. Our solution was a fundamental change to the medical workforce model, so the implementation of a rural generalist. And just to be, to cut it, sort of do it in 2 seconds or 1 minute, is see all those boxes, which you might not be able to read very well. That's like going specialty by specialty: pediatrics, orthopedics, O&G, et cetera, And what we did is we changed the workforce to a rural generalist workforce. So instead of having 4 SMOs with orthopedics, 4 with O&G, all of that, we moved to a rural generalist, so rural hospital medicine specialist trained with primary care as part of their core base or core degree. And then we, go to the next slide. Speed it up. And then we went to Medical Council, worked with Medical Council, and introduced into New Zealand an enhanced skill set. So these professionals, these rural hospital medicine specialists, were able to have what Medical Council called enhanced skill sets. So not an extended scope, but enhanced skill sets to let them do procedural skills. So to be able to do operative caesarean sections, to be able to provide some operative gynae procedures, which then meant that you have more generalist cover. And instead of having 4, you can often have one. And it's not just about cutting down numbers at all. It's actually about a whole reframe of primary care, because at the heart of these guys' qualifications is primary care, is staying in a community, being part of a community. And so that's my whistle-stop tour of that. You can read, you can see my slides aren't very good either. I was getting slide envy seeing all the people before me with all their professional things, and I was like, damn it. Mine is like 2005. But you'll be able to get these slides later. I guess the key thing I would say is it's not like this is still a work in progress. Like any change, it's still a work in progress. There was massive change that we had to go through, particularly with the union, with ASMS. And actually the biggest support came from our community, came from iwi, and then actually that was the platform for when we were doing our localities work. Rural generalism was one of the things that was our platform for our localities development. So the one thing I'd say before I go to my next whistle-stop tour is there is an opportunity to use this model in other parts of our country for areas that have lost procedural obstetrics. So think of places like Taupō, Kaitaia, where actually women have to travel massive distances to go to Whangarei as the base hospital. So we've had whakatane who have an unsustainable model, or unsustainable in terms of, they can't recruit ONGs there. They're also interested in the model. So it's just, how do we take the learnings from places where we have implemented and then scale it? So the next whistle-stop tour is the maternity assessment unit here in Waitaha. It sounds really simplistic, and it's actually really simplistic, but it did take quite a bit of work. And I just mihi to Norma Campbell, who was our director of midwifery at the time, and actually mihi to Gary Coughlin, who's many of you will know, our good friend, because he was a big pivotal piece of our what I talked about before with rural generalism. So just want to acknowledge him as well. So this initiative was about us realigning service provision. So this wasn't so much of a workforce change, but it was a service and model of care change. So traditionally in this hospital, if you came in for an antenatal assessment while you're pregnant, you would go to birthing suite. And so what we had is basically birthing suite would look after you in labour, but you'd also come in there for assessment. And so what we wanted to do was separate that out and have two different spaces. I know it sounds really, really simple, but as we know, within these sort of health systems, nothing that sounds simple is ever that simple. So we wanted to create more capacity within birthing suite to deal with really acute presentations and intrapartum care. And actually we wanted a more culturally appropriate space, because the space we had on birthing suite was tiny, squashed. The whānau room was like just tiny, like would fit only a few people in. It was not appropriate. Just quickly, key reasons why you'd use the maternity assessment: reduce fetal movements, abdo pain, query rupture membranes, APH, etc. You can see it all there, and you can do planned day assessment and antenatal assessments. So get to the good stuff. So what we found, and this was an average over a year, we ended up setting up the space, which is in a physically about a 2-minute walk from the actual Christchurch Women's. So it is actually in this building, which was interesting. So that came up with a lot of challenges, because clinicians were like, oh, how can you have an assessment unit, 3 minutes away? You need it right there. We need it through the doors. So that was probably barrier number one. But we ended up taking, and it's still up and running and still going, about 200 attendances off birthing suite per month. So we quite quickly were able to demonstrate that you can do something in a different way and you can change flow. One big thing was our average wait times for women in whānau who were coming to be assessed. That went from 3.5 hours average to have an assessment if you were on birthing suite to 1 hour 57. So we decreased about, that was a decrease of about 47%. So the key outcomes, roughly, we've got about 2,500 women who are not having to go to birthing suite. It actually we had to do it within our current budget. So these things, and actually what I didn't say to you before is rural generalism saves us millions per year as well. Like, these are all things that actually save money and are not about doing things and needing more. Really importantly, we've had such good feedback from whānau consumers and maternity staff having a decent, welcoming, appropriate space for them to be able to use for assessment. And really importantly, about 17 or just under 1,800 women are being seen in MAU and sent directly home. And this is a midwifery-led unit. So this is midwifery-led discharge in a tertiary unit, which, if those of you who don't know, midwifery and maternity is a big deal, because quite often in these tertiary units and secondary, it's medically led, and no disrespect to my medical colleagues at all. But actually, I think us as midwives, as nurses, as allied health and technical need to start claiming back a bit of our autonomy and what our scope of practice is. And we are fully able as midwives to be discharging in a tertiary unit with our skill sets and working to the top of scope. Now, final whistle stop tour, Te Aka Whai Ora. All of you know about Te Aka Whai Ora, the Māori Health Authority, and I was privileged enough to be in there for the last year and a bit within HNSS. And I just want to acknowledge also my tiny team that was in within HNSS that I got to work with. So we were looking at hospital and specialist services from a national perspective, asking all these sorts of questions when we had the national SLT that some of you might have known about under Fiona Dugan, and the establishment of a lot of the data sets to feed into one, and obviously now with the health targets. I'll go quicker so I don't take too long. I've used this as an example. So SB5, for those, it might sound like gobbledygook, but just to give a bit of a outline, we have 5 key health targets. Actually, we have 5 plus 5 plus 5 plus 5, but I'm not going to go into all of them. But the 5 key health targets that our minister looks at is SB2, which is FSA or first specialist appointment, SB5, which is I'm going to talk about, SCCD, so shorter stays in emergency department, FCT, which is cancer, and IMS. And one of our jobs in Te Aka Whai Ora and HNSS was to look at what was happening in these health target information that we were collating. And the first thing was even getting an ethnicity breakdown, and that might sound really crazy to you all, but actually even being able to see that was a massive battle in getting the data disaggregated. So it was like big mountain number one, was to even get disaggregated data so that we could see what was coming through. Now, the feeds that are coming through for the health targets are weekly. So weekly, nationally, Health New Zealand look at the data coming through and send that to the minister so they can monitor. So what we were doing before we were just established is we were starting to set up, so we were able to see ethnicity broken down for the health targets. With SB5, what we were doing is basically being able to see at a district level and then aggregate it up to regional what was happening for Māori patients in different areas. So we were able for SB5, that's about treatment, five minutes. And so we wanted to set up an equity waitlist response and actually and IST, which is intervention support teams as well. This allowed us to monitor Māori patients, particularly those waiting over 365 days. So that's what we call the long waiters. Key in that is the data that we see, or the data we were seeing, it's not even, so 365 days is 1 year. It's not that we're seeing people at 366 days, 367. We're seeing people up to 5 years, and then actually sometimes you'd see more, but quite often it would be a data anomaly. And so our focus was on actually seeing the longest waiters and prioritising the longest waiting Māori in those districts, and actually being able to work with those districts to say why have you got 40 people, and actually my last point here, on your gynae list or on your ORL list or on your orthopaedic list. So starting to drill down. I've just put this up, I probably have to go real quick. Basically what this is showing and what we were able to do before we were disestablished is start to look at the differences. So from RAPID, so that's the data set that we have in Te Whatu Ora, starting to see the differences in wait time. So average days on wait list for Māori before the reform started. And then we were looking at 6 months after the reforms had started, and then right through till the end of last year. And actually what you can see is it didn't get better. Then it started to get better, but it's actually worse than when we started pre-reforms. So in summary for this change, Māori continue to experience inequitable access to elective treatment, continue to be the longest waiters, and the key thing for us is what actions could we take to address this? So quickly, key considerations. I'm not actually going to go on that too much, just I think change moves at the speed of trust, and how do we not lose the gains we've made? I put up this curve because I think we're all in frustration and disruption in the health system at the moment, but hopefully it gets better. And then I just, this is my last quote, is insanity is doing the same thing over and over again and thinking that we're going to get a different result. We cannot continue to do the same thing we're doing and think we're going to get a better result. So, nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa.
Gosh, you promised us a whistle stop tour and you meant it. It was like, woo! And I think that graph around where we're at now and frustration is a very nice articulation, whether we're in health research, around the health research funding, or whether we're working in the health settings. So I appreciate that. I wondered if the Albert Einstein quote should be sent to the current government, but we'll just see on that. Thank you, Laura.